not to waste any time whilst that's coming up, I wanted to start by asking you all a question, actually. So if Gabrielle, which he's not going to do, gave you 170,000 euros today for reducing HCAIs or infection prevention control, what would you do with that money? Just have a think. So if somebody gave you 170,000 euros today, do you know what you would do with that money? Okay, and I'll come back to that in a little while, why I asked you that. Okay, all right. So I'm Raheelah Ahmad, not a clinician, not a clinical background, from a management background. And management background in terms of having practiced in management in the National Health Service in England, and then in research at Imperial College. And some of the work I'm going to present today is from our research unit, headed up by Professor Alison Holmes, and I've got my colleagues here, Dr. Shirani and Dr. Castro Sanchez, who will be running workshops this afternoon. So the title of the talk is kind of reflective of some of the things that have been coming up today already, which is when you're trying to implement infection prevention control strategies, there are lots of priorities, and some of those come from, outside of the organization, the outer setting, as has been described by the CIFA framework. So I hope I can call it the CIFA framework because we're all familiar with it now, and we're all happy to call it that, or the macro level. So macro level is anything outside of your organization, and we're kind of assuming that most of us are from hospitals, but we mustn't forget about primary care, social care, and other areas. So anything outside of your organization. And then we're looking at things that are at the organizational level, usually your hospital, and then obviously your individual. So you can see how this maps to the CIFA framework that we've been looking at. And I'm just going to spend the next 20 minutes I have, I think, to just say what have we found when we've looked at the context of IPC and implementation, specifically in the National Health Service in England. And that may sound a little boring because it's one country and one system, but the reason I've focused only on England in this talk this morning is because we've heard a lot about how context is important. So what happens if we keep the context the same, and then we can look at the inner setting and the individuals and the processes? So hopefully you can then map that to how it is in France and look at your context and then see what's different and the same in terms of those inner settings. So I've been a bit bold, knowing that there's no magic bullet, as you quite rightly said at the beginning, but we've put up some messages for what we know, that if you don't have this, then implementation is likely to fail. So while this is not the magic list, it is a useful list, we feel, based on our research, as to what, if it's lacking, you won't get success. Okay, and you can challenge me over lunch later if you like. Okay, all right, so the first one is organizational slack is necessary. And what do we mean by organizational slack? That means that there is space in your organization, either through time or resources, to allow you to implement, to innovate, to think, and to assess evidence. So we talked about Cochrane, if you've got the evidence, then evidence-based guidelines, you should see implementation. But we all know, all of us individually, what do we all do? Oh, who wrote these guidelines? Where did the evidence come from? Is it relevant to this context? So we do some reassessment. So having that organizational slack. So what does that look like in terms of England? We looked at what does organizational slack look like. And we used quite a crude measure. We used number of staff in a hospital, over 9 hospitals, and looked at how innovation, adoption, or implementation had happened, specifically for infection prevention and control. So only those interventions. And when we did this, if you just think about the CIFA, we're looking at the inner setting, as I've said. So this is what we found. If we use number of staff along the bottom there, and then along the vertical axis, you've got the number of interventions around IPC implemented in the same time period. Does anybody notice a pattern there? Anybody want to say what that looks like? Observations? Yes, you're doing that right, yeah. Do you want to say what that was? U-shaped, absolutely. So it's a U-shaped curve, and maybe not surprising, because we know that, I know we like to think that healthcare is very, very special, and it is, but if you went to a small-sized firm in any other industry, you'd find that they were the innovators and adopters and implementers. If you went to the larger ones, they would also be, but it's the ones that are the squeezed middle find it harder, and exactly the same when we looked at hospitals in England. Okay. The dangers with that, or the risks, are that with a smaller hospital that is innovating a lot, they can be subject to innovation fatigue, and you talked about, Walter, about hand hygiene fatigue there. So it is possible. And then the problem on the other side is that if you are a large hospital and you have got resources and capacity and headroom, you may just be throwing everything at the problem all at once. We know that multimodal interventions work. However, having lots of multimodal interventions all at the same time can be unhelpful when you're trying to evaluate to see what actually worked. Okay. So the next one is professional perspectives. We've heard a lot about that, so I'm not going to reiterate what's been said, in that we all have different perspectives on evidence, on what we think is useful, but there's also the issue about power relations and hierarchy, and that will be different in different settings. So again, if we go back to the CIFA, we're looking at the individuals involved, so just linking that back. So here, these sources of guideline and evidence were all those that were available in England during our period of study. So that's what you've got around the circle. And we don't need to worry about what they are, but you can see there's the Cochrane, the NICE guidelines, and all sorts of other resources. And this is how doctors behaved in terms of using that evidence, the darker area. So, and the lighter area is their awareness. So they're fairly aware, but not aware of everything. So when we looked at how this differed for other professional groups, we can just try and keep that image in your mind. This is how nurses were aware and how they used that evidence. Remember, this is all England, so it may or may not be the same for yourselves. And then what do you think the pharmacists will look like? Closer to the nurses or the doctors? Who thinks they'll be closer to the doctors? Put your hands up. Okay. Who thinks they'll be closer to the nurses? Okay. So they are actually closer to the doctors. Okay, and that could be for a number of reasons. Their perceptions in terms of what they think is good evidence, useful evidence, influenced by peers, but also their clinical training, which is different to nurses. But also nurses have a sort of a broader role. But nurses in IPC in England particularly have a role of convincing the doctors and pharmacists to do things. So it is kind of their job by de facto to look at evidence from a broader range. So that could be an explanation. Okay. That said, when we asked them, how do you find the evidence that's presented? Is it helpful? Is it useful? Is it that clear? There's not a huge difference between what doctors, nurses, and non-clinical staff thought. This is 130 professionals, again, in England. Okay. And I do want to mention the word evidence again, because in England, a lot of debate around the evidence for interventions. Interventions that sometimes were pretty common sense things, and the healthcare professionals took it upon themselves to question the evidence and start resourcing, actual studies to refute evidence, and that's probably not a good use of anybody's time or money. But it was a sort of a message to say, well, if you're asking me to do something, well, here's some evidence to say that we do not need to be below the elbows or all sorts of other things. So, how do we manage that? So from a managerial point of view, I think the point there about coercion and helping people, supporting people, yeah, we can be supportive and helpful, but I think when things start to happen that don't need to happen, I think that's when you have to help and say, this is common sense now. So you kind of have to move that way. However, you have to still help people, because you can get people on the front line who can just down tools and decide they're not going to do something, and there's nothing that a chief executive or anybody else can do, no matter what the consequences might be. Okay. And then just on the point of evidence, I think it's also important to say, where do we have these debates about evidence? Because evidence obviously is evolving. Research is happening all the time around us. And sometimes it's really unhelpful to have those debates in public. And this is an article that was published about a year ago in England in the British Medical Journal. And it was almost like an opinion piece. And it was, I don't know if people have read this, but it was questioning the, should you finish your course of antibiotics? And of course, The Guardian picked it up, the BBC News picked it up, and it kind of really was an unhelpful way of mobilizing this kind of knowledge in the public domain. The next one is culture matters. So, as Walter said, culture can be just the way you do things around here. But what we really need to be able to do is to capture culture in a way that is a little bit more helpful. So are there indicators that we can use and so forth? And for the CIFA framework, that's about the macro context and the inner context, because those two come together to define the culture for organization. So Asmita has done a lot of work on this, and she'll pick this up in her workshop later this afternoon, but I just wanted to pick up some of the key points that had come out of that work, that there is an influence of hierarchy, accepted non-compliance to policy when others are not doing the same. And the hierarchy of prescribing is not just something that happens in England. Work that was conducted over 53 countries also showed that the biggest determinant as to what decision you made about prescribing across professional groups was through what your seniors were doing. And we often think that cost is a consideration, but when we looked at cost, there was no clear pattern there. So how do we gauge organizational culture? Walter will talk later about the components of this review in the workshop this afternoon. But there are some really important and useful indicators that you can use. So work satisfaction, how your organization responds to an emergency or crisis. The levels of absenteeism and turnover in your organization can be good indicators. But organizational culture is not enough, is what we say from our work, that you do have to have something in your organizational form in terms of your structures and your organization, because if infection prevention control and AMS is completely absent or invisible from your organizational structures, and however they are organized, then it means that the resources cannot follow that work. It's not identifiable. It means lines of accountability are not clear. So I wanted to follow on from that to say that if we then view infection prevention control programs or interventions and AMS programs as process innovations, then we can learn and apply quite practically, and I think take on board Celine's point about, how do we really do this now? So we can take some of that as to how we use that in process. And we talked about innovations, and we know the theory of diffusion of innovations. It's an old classic theory, and it was included in the CIFA framework or assessed at some point, but this is the very simplified early version, just to say that when you're actually looking at an intervention and you're looking at the group in which you're targeting, then it's just worthwhile segmenting that population at the bottom there. Who are the innovators and the early adopters? And the word laggards is a little bit unattractive, but sometimes the laggards are the people that you need to talk to first. So the question is really, who do you start with? And I know in Asmita's work that she's found that the laggards are sort of the specialists, because they are the ones that are questioning the evidence the most, or saying that this doesn't apply to what we do the most. So it's useful. So I'm coming back to my question. I don't know, Gabriel, we've gathered the money yet, but if you've got 170,000, I've still got the pound sign. It is euros, it's not pounds. And the reason I asked this question, is because this is exactly what happened in England. when we were carrying out these studies, this is the amount of money that was given to trusts, so groups of hospitals that had achieved best turnaround in their health care associated infections. And it's really important to say turnaround. It's not to say who were the best. It was those that had improved the most. So they were given this amount of money and said, you can actually spend this money on anything that you would like, so long as it's aimed at preventing infections. And these hospitals were followed to see what they did with that money. And we have some publications to say exactly what they did with that money. And I was going to say I'd encourage you to read them, but don't read them, because we can just tell you quickly what the messages are, because you don't have time, and we've heard that message loud and clear. So what did we find out? We found out that when they were given that money, there were a group of people that knew exactly what they wanted to do. They had already thought this through. The IPC teams had thought this through, and cost had been the barrier. So what they did was they said, okay, here's the money, let's go for it. And there are some problems with that, as you've heard already. So the message that we can give you from having followed those hospitals and what they did with that money and what worked and what was still sustained 2 years later is those hospitals that involved people outside of the core IPC team at the earlier stages, initiation, decision-making, or implementation planning, were the ones that 2 years later still had that intervention there, okay? And there were some really, probably not surprising to you as you work in the field. There were some examples where things had been implemented which in another part of the hospital had been implemented, a different brand, so that sort of thing. So it sounds almost obvious, but that's the key take-home message. The problem with that is it takes longer initially. We know that if you're consulting outside, but as Walter said, if you're talking about sustained change, you have to have that investment up front for sustained implementation. So what does that kind of involvement look like? That involvement can be, right at the top there, information giving. So just letting people know we've got this money or we've got this initiative. And then the next step is information giving with opportunity to feedback for your staff. And then in the middle there is the shared kind of equal role. And then there's the slippery slope where you give the dominant role to other people. And that's probably scary, but it can work. And it worked in one of the hospitals where we saw the best sustained impact, where they actually went out to a full consultation, got 100 applications across the hospital. Some of them were a bit far-fetched, flooring, because it will have an impact on IPC in some convoluted way. But, and they were rejected at the first stage. But some others were really good, like refurbishing an endoscopy unit and the cleaning facilities around that. And they had gone to, the dimensions like good ergonomics. People were off sick with back pain because they were not able to work in these facilities, and they actually, they actually won some of that money to carry that out, and the outcomes were IPC related. So it's interesting what can be done if you actually open it up. So does it matter opening it up? As I've said, you could be looking at a better range of problems, wider range of problems and solutions if you ask outside of the IPC team. And really, if you're looking at your outcome as being sustained adoption, then the message is that yes, it does work. So what does that all mean for IPC, for all of us? For professionals, remember the role of evidence and how people perceive evidence. Remember about hierarchy and role modeling. So if you're a professional, everything that you do does have an impact on others, depending on who you are. Organizational leaders is hard, but you do have to create that organizational slack somehow, and that doesn't always mean with money. It can be with the way you organize your team or your week, and all sorts of other ways, and you could be thinking about how you could do that. And some of that time needs to be about debating that evidence, reassessing it, and parking what does not need to be reassessed and saying, this is what we're going to do, we are going to do it, and we can let others update the evidence, we can just carry on and do what needs to be done. And then if we're going to say that infection prevention and control is really everybody's business, because that's the mantra, isn't it? Then really we have to make it everybody's business in everything that we do. And then the message that comes from the CIFA framework and from the two previous talks is about you do have to take time and you do have to involve others, and it is about implementation at the whole organizational level. So that's all I want to say, except to say that this afternoon's workshop will look at the macro level. So here you've seen we've skirted over the macro level. We've said it was very complicated and complex. But this afternoon we will look at the macro level, so regulation and all the rest of it. Thank you very much. Thanks.